welcome to this edition of Inside COVID Siege. We are going to be talking today to four of the healthcare heroes who are featured in the series. First, my name is Courtney Crowder. I am the Iowa columnist at the Des Moines Register and the writer behind the 7-part Inside COVID Siege series, which finished up this Sunday. In that series, we brought people inside Mary Greeley Medical Center in Ames, Iowa, to be by the bedside in the meetings as people were making decisions around how to fight the coronavirus inside the hospital. We hoped and we strived, and I think we did, tell stories of dedication, sacrifice, exhaustion, loss, pain, joy, and all of those emotions behind the hospital doors. I'm going to bring some of the people that you're going to be hearing from today. So first is Zach Boyden-Holmes, a senior photographer at the Des Moines Register and the person behind all the photos that ran with the Inside COVID Siege series. Man, that is a tongue twister when you say it out loud enough times. Welcome, Zach.
Thank you.
And joining us are four of those healthcare heroes. I'm going to ask each of you guys to kind of wave as you're introduced. So first, Dan Fulton is an infectious disease specialist who's worked at Mary Greeley for almost 6 years. He was the hospital's sort of standard bearer during the pandemic, and his eternal optimism earned him the nickname Mr. Rogers, and he'll be the first person that we talk to. Also with us today is Dr. Tamim Maani, the medical director of the ICU at Mary Greeley, where he's been for about 3 years. Hi, Tamim. And then Nurse Julie Siebel is the nurse manager of the ICU, and she has been there for the longest of all of our participants today, about 13 years. Hello, Julie.
Hello.
And finally, Nurse Margie Dyson, who is shift lead on the med-surg floor, which around this time last year became the COVID floor. She's been here at Mary Greeley for about 4 years. Hi, Margie.
Hello.
Welcome to everyone watching today. Thank you so much for being here. Today, our conversation is going to look forwards and backwards. We plan to talk a little bit about what this past year has looked like, as well as how these four wonderful people think what we've been through will affect you, them, and their colleagues moving forward. We do want to give the audience a chance to ask questions, so please find the chat box, whether it be on Facebook in the comments, in YouTube in the comments, or here in the comments to type some questions. I'll be going through those as we talk, and we'll make sure to bring those to the forefront. It's really your show. We want to make sure we're answering your questions. So first, I want to start with you, Dr. Fulton. Mary Greeley really had two surges of COVID-19, one in late April and early May, which was made up of essential workers, basically, mostly younger people who were able to survive the virus a little better than the second wave, which was in November, which is a lot of elderly people. Tamim explained it as, grandma and grandma, grandma and grandpa, who had a harder time surviving. So Dr. Fulton, as the hospital's infectious disease doctor, you've been part of the conversations about fighting COVID-19 since there were conversations about fighting COVID-19. How does a hospital like Mary Greeley prepare for a pandemic, and how did you see that preparation come to bear as the surges hit?
Yeah, thanks, Courtney. So every hospital has an infection prevention team that focuses on preparations for pandemics and has a degree of surveillance that they're doing all the time. Some people might remember when there was kind of an Ebola scare years ago, 4 or 5 years ago, that was something we were engaged with then, H1N1 in 2009. So these are things that infection prevention teams are monitoring. And I remember the first reports coming out of China that caught my attention were not necessarily that there was a new virus, because we hear that from time to time, but that China was needing to build field hospitals. And I think that was quite alarming. And so we convened what's called an incident command team at the hospital, which basically brings together everybody from nursing for bed management to lab folks to administrators to physicians, that just the whole team, to find out how are we going to prepare and be ready for something like this. But so much of that is happening as more information is becoming available. So at first it starts with a lot of meetings, a lot of monitoring the situation. So much was changing at the time. And basically we started watching what was going on in Italy with the overwhelmed hospitals there. And then with more alarm when we started seeing overwhelmed hospitals in New York. And we used the experiences that those places were having to try and imagine what it would look like in our hospital if we were overwhelmed with patients who had needs. And so we kind of worked through scenarios. And, I actually think we got to a point in March where COVID was just starting to come into the Midwest. It kind of hit the coast first and then came here. But I remember one meeting at Mary Greeley where we went around the incident command room, and to a person, every single person said, we're ready. We've done the preparations we can do, and now we're waiting. And there was actually a time where it did feel like sort of the calm before the storm. We had done what we could do, and then the patients started coming in. And I remember one experience where we had a patient who went to the floor and was transferring the medical floor and then was transferring to the intensive care unit. And it felt like there was a lot to do, but the respiratory therapist said, this is what we prepared for. So I think a lot of what hospitals do and infection teams do is try to imagine what might happen, prepare for it, and then continue learning every day based on real experiences about what was it actually like and how do we do better.
We did the bulk of our reporting there in December, though we've been back in January and February. What has happened since the bulk of our reporting in December? What's the hospital like now?
Yeah, as you mentioned, we've had two definite waves as far as the hospital is concerned. And that first wave, we saw a lot of frontline workers who weren't able to stay home in April. We also saw a number of nursing home residents early on. And they did tend to be younger, and so their hospital stays were quite long as we did what we could to support them. And we then saw a period over the summer months and early fall where we never had no patients, but it just seemed like there was only a handful at any given time. And then in November, it just felt like a rising tide where every single day there was 3 or 4 more patients than the day before. And we walked right up to the edge of our sort of surge capacity when sort of the tide crested and then started to recede again. To me, it really spoke to the planning that Mary Greeley had done to be ready, that we were able to sort of handle that surge as it came. Since then, we've seen sort of steadily decreasing numbers. The tide has slowly gone back down until I think there was 2 days last week or the week before where we actually went a few hours with nobody in the hospital. We have, I think, a number of people in the hospital now and 3 in the intensive care unit. I met with a family this morning of a patient that is not going to survive. So it's not over. There's still work to be done, and we need to keep, doing what we can do to protect people, especially as the vaccine is getting rolled out, and stay vigilant. And I hope that in the coming months, we'll see fewer and fewer cases, and get to the point where COVID is not a daily reality, but maybe something that happens, sporadically that we're ready for, but isn't kind of overwhelming people.
Right. Keep your mask on, keep socially distanced for sure.
Yeah, I think so. And I don't mean to interrupt, but I think I get a lot of questions from people about, if I get a vaccine, why do I need to do that? And I just think it's a question of math for now. The vaccine is effective. It's very effective, but it's not 100% effective. And we don't always know, the people around us, if they've been vaccinated or not. So I think my hope is that as the numbers in the community go down and down and down, we will get to a point where we can all start to safely be together again, even with people you may not know well, and not have to wear a mask. But I think until then, my advice is people should keep wearing them to do everything we can to bend that curve back to zero.
Awesome. Absolutely. And please do not apologize for interrupting me. People want to hear from you, not from me. But with that understanding of kind of where the hospital has been, let's go back to December. And I want to watch this 90-second video really quickly.
Our nurses, and my experiences mostly with our ICU nurses, are one of the bright spots of the hospital. I wouldn't trade our nurses for anything else. They are exhausted, but every day they get up and they come to work, and they've covered extra shifts. They've worked longer shifts. Julie picks up shifts. You can see it on them. They're tired. They're emotionally tired.
I mean, are we burnt out? Yes, but this is what we do. Again, you ask Wanda, who shows, if I call her and told her, could you work at 3 a.m. tonight? She'd say yes. And then at 1500, when I'd say, could you stay? She'd say yes. And then I'd say, can you come in at 3 a.m. again? She'd say, are we short? And I'd say yes. And she goes, am I your only option? I'd say yes. And she'd say yes.
But all these experiences are experiencing this that someday need to be unpacked and kind of thought through and dealt with from an emotional standpoint of, you know, what they're facing. And, you know, but when the next wave is coming, you just pack it away. We'll deal with that later.
If you've had discussions before saying, I don't want to be put on life support, now's the time to have that conversation. In the last day or so, you've gotten worse. And if you continue to get worse, then that's a real possibility that you're going to be on a breathing machine. I don't know if it would help or not. A lot of people, it hasn't helped. A lot of people, if they get to that point, they end up dying.
Now I want to bring on some of the people you saw in that video, Tamim Maani and Julie Siebel. Dr. Mahani, to start with you, so many of the issues brought up in that video, and that's just a clip from a longer, about 5-minute video, but talking about end-of-life care, talking about those decisions at the bedside, talking about exhaustion, were really very much realities when we met in December. What are you thinking and feeling as you look back at that video?
I mean, the video it's intense, but it's real. That is how we felt. That's how we feel. Unfortunately, end of life care is something that we deal with all the time. It's a routine part of my job as a ICU doctor. And so that conversation that I was having with her, it's not a new conversation for me to have. It's never a pleasant conversation to have. But I think COVID created a very particularly harsh situation that made it incredibly difficult. Because we just don't really know, and we still don't really know what predictors of success a patient may have. There was no reason for certain people to do poorly and other patients do just fine, and that unknown is really difficult. So when you're sitting there with a patient, letting them know that they're getting sicker, the hardest thing is to be honest with them, but also not to take away all their hope. You don't want to just walk into every room and just let them know, you know, they're dying and there's not a whole lot that we can do. We want to give them some hope because maybe there is some, but we just don't really know. I think the exhaustion that you guys felt in our ICU at the time was very real. It was a rough tide in November, roughly around between Thanksgiving and Christmas, was hopefully the toughest time we're going to have for the remainder of my career. It was just nonstop. And the conversations are hard. They take time. And particularly that it was very hard to, how do you tell, you know, grandma who was fine at Thanksgiving, who felt maybe a little bit poor in December, around early weeks of December, that she's dying around Christmas and your family's on FaceTime and nobody can really be there, and it's just those conversations over and over again were exhausting. I guess I can't speak for everybody. When the numbers go down, you start to breathe a little bit easier, but there's always that anxiety about if that next tide, when that next tide is coming. I don't know if it's going to happen again or not. I think, we're still having cases, like Dr. Fulton said. But yeah, that was a particularly tough time.
Julie, one of the other things that I was really struck by is, Mary Greeley is a community hospital. It serves its service area in central Iowa. People in central Iowa really love it. And a lot of the people who work there have ties to central Iowa. Tamim is an Ames native, you're an Ames area native. How difficult was it for you and for your nurses to know people coming into the ICU? How much harder did it make that dealing with those patients?
It is terribly hard to figure out is someone's family member. And when we always got the call, okay, you're getting an admit, you always kind of held your breath, wondering who it's going to be. Is it someone in our community? Again, is it someone we know? So that was always really hard. Because again, we just didn't know how these patients were going to do. They would be here for a few hours and look okay, and then the next minute they wouldn't. And we were bringing Dr. Mahani in, respiratory therapist, and everybody to try and get them better. And it's just hard when, like I said, there's someone's family, neighbor, someone we knew. It was just such a struggle.
Another question for you, Julie. Tamim talked a little bit about the exhaustion of those late fall months. When you're deep in that second surge, 7 people on ventilators, flipping, proning 6 different people, people are dying. When you're in that, how difficult is that for you as a nurse?
It was very difficult. It was difficult to watch my team work as hard as they did. And Dr. Mahani says it so beautifully in there. They'd go home, they'd work long hours, they'd go home and show back up. And that's just what we did. We just learned to deal with it in that way. But again, you could see it on people's faces. You could feel it. They'd come in and say, I can't do COVID today. But we didn't have an option. There was nothing but COVID at some points. And we just had to learn how to get through the day and give the best patient care. We got other people from other departments, PACU, ACS, who would kind of come up and help, and that was very valuable to help prone these patients. It takes anywhere from 6 to 8 people to prone a patient. Someone's got to watch their airway, their lines. So we just learned to come together as a team and use all our resources within the hospital to give, again, the best patient care that we could for these very difficult and very tedious patients that would be here with us.
And Mahani, same question to you, but particularly, I remember when we first met and you said, I love being an ICU doctor, but I do not like being an ICU doctor in a pandemic. Tell us a little bit about that for you. I think you're muted. You are muted, Dr. Mahani. So I do want to have the answer to that question. But in the meantime, let's go ahead and switch over to my colleague, Zach, who is going to talk to Margie Dyson from the COVID floor.
Hi, I'm Zach Boyd-Holmes. I'm one of the photographers at the Des Moines Register.
Yes.
How are you and Margie?
Pretty good. It's a good day.
It's great to see you. So, you were on the med-surg floor, which became the COVID floor. Can you just start by talking to me about how med-surg is the COVID floor that it became? How is that different than the ICU?
Yeah, so typically we get like ortho patients, general surgery patients, and so we're used to a very different population. And then a year ago, they decided since we can control our census better on our floor, it would be best for our floor to become the COVID floor, which when that first happened, that seemed very scary because we're like, what? Surgical nurses are handling a pandemic, but Mary Greeley did a really good job of, preparing us and educating us and answering any questions. And so we had to kind of switch our thought process as surgical nurses, because we usually get our patients and they're, if they're having surgery, typically they're already pre-checked for surgery and they're healthy. And so we had to go from being fixers to having patients stay longer and trying to figure out what the next step is. So we had to change our thought process.
Yeah, it was really interesting to see. Courtney and I were both struck by how young a lot of the nurses on your floor are, and in talking to them, realizing that they're not used to dealing with sick patients. You're used to dealing with people who are just had a hip replacement, and you help them walk again, and they leave in a couple days. So, talk to me about how did you counsel your staff to handle those changes, and how did they handle those changes?
Yeah, so a surgical floor, a lot of medical telemetry floors or surgical floors, they have newer nurses anyways, because that's where a lot of nurses kind of get their foot in the door and get experience. And so it's different for experienced nurses and new nurses to be dealing with the pandemic. But then to be a brand new nurse and come straight into a pandemic was probably really difficult. You thought you had this idea of what kind of nurse you were going to be, and I'm going to do great. I'm going to pass all my meds on time and do all my assessments and make these amazing connections with patients and their families. And it turns into, wow, I need to change my whole thought process and how I'm going to take care of my patients and how I'm going to communicate with family and how you're going to fulfill that, what you thought you would be as a nurse and what you are as a COVID nurse or a pandemic nurse. So I think for all nurses, new and experienced, we had to really support each other and talk about it. Mary Greeley, they offered lots of counseling services and resources, but just even on our floor, our leadership, they promoted conversations like, hey, how are you guys feeling? What are you feeling? What are your questions? And a lot of people reached out to each other, whether it was through calling each other, texting, and we had like a Facebook group, we'd post things to kind of uplift our spirits. But I think it would happen a lot on the floor when we'd be like, hey, how you doing? I know your patient's kind of difficult, or your whole group's difficult, or you just had a patient pass. Let's go and talk about that. And so I think it was from nurses just talking to each other and saying, hey, I feel that too. And I'm experiencing those thoughts too, and wondering what I could have done better. So I think we're lucky that our leadership and management and just our coworkers all supported each other and kept that conversation going.
That's great.
I want to bring Dr. Fulton and hopefully Dr. Mahani back into the conversation here. Dr. Mahani, can we hear you?
Can you hear me?
We can.
I don't know what I did, but just click a bunch of buttons and see what happens.
So I want to have you answer that question that we were talking about before. You told me early on you love being an ICU doctor, but you don't exactly love being an ICU doctor during a pandemic, and especially when that second surge hit. So tell me about that.
Yeah, I mean, I think ICU is fun. I obviously enjoy it. I wouldn't have chosen this path if I didn't enjoy it. A lot of the times in the ICU, we have to be comfortable with the unknown, meaning this patient is sick. Let's provide them with the support that we can while we try to figure out what exactly it is that's making them sick, whether it's respiratory support, oxygen, blood pressure support, antibiotics, steroids, whatever it may be. And that's always been enjoyable and fun for me. COVID created a lot of unknowns, and there was a lot of debate in our world about what it was that was making people sick. There's a lot of medical terms that we could throw out, but there was a lot of debate, particularly in the pulmonary and critical care world, as to why are people getting sick and how should we be managing this? And just the general public could kind of see that pendulum swing. I mean, last year, if patients were on very little oxygen, they were proceeding very quickly with putting people on mechanical ventilators. The pendulum swung very hard towards the other way of, let's do everything that we can to keep people off of ventilators. So that swinging back and forth with the unknown when the cost is life is really hard to know. On top of that, it was almost a year ago, it was meeting after meeting after meeting after meeting. One of the meetings that I was involved with, and Julie was involved in this too, was an ethics committee meeting. So most hospitals, if not every hospital, has an ethics committee. That's not necessarily all healthcare workers. We have faculty from Iowa State involved in Mary Greeley's ethics committee. And I was asked to join that to talk about resource allocation. And then you just get stuck going down this mental rabbit hole of, what am I going to do if we run out of resources? What am I going to do between choosing my mom, who may need something, versus somebody else's mom who may need something? And those are not fun thoughts to be dealing with. And that's something we had to plan for. And it's just not particularly enjoyable. And so that's kind of what I was trying to imply is I do enjoy ICU. I do enjoy critical care management. But the last 9, 10, 12 months have not been enjoyable with that regard.
Right. When the cost is life, I mean, wow. Obviously, but sometimes those things just hit you and you're like, right, the cost is life. Dr. Fulton, these are a few questions from our audience here. First, a lot of people are interested in long haulers and kind of the lingering effects. So what's the long-term prognosis for long haulers, and does age make a difference in that?
That's a really good question. And I don't know that anybody knows the answer or has a good answer, because even here in the States, we are just 1 year out from New York's first wave, and our November big wave is one where we are seeing now a cohort of folks coming out of that wave that are continuing to have symptoms, and so that's being called long COVID or COVID long haulers. And what's interesting is patients that have been in the intensive care unit and quite ill, regardless of the cause, often have lingering symptoms related to their critical illness. And I think that's sort of what we expected COVID long haul disease to kind of be related to. But it actually has turned out that many folks that maybe had mild symptoms all along then transition into this sort of persistent illness that has a myriad of symptoms, and it can sort of act differently in all sorts of folks. As an infectious disease doctor, I've taken care of people for years or over the years that have had some infectious illness, and after they sort of recover from the first illness, they then go on to have persistent symptoms. We call those post-viral fatigue symptoms. Sometimes that's chronic fatigue, but they're often instigated by some illness. The challenge has always been that they're very rare. And so how do you get enough folks together to really try and understand that disease process and why it's happening? And so I think a unique opportunity of COVID-19 is so many people have these symptoms now after COVID that there's huge research studies being done into this post-viral phenomenon that I am very hopeful will find answers that we never had before to help not only COVID patients, but other patients. My experience with non-COVID related post-viral fatigue is that, or associated symptoms of body aches or brain fog, is that they do fade over time. They do generally seem to get better. Not everyone, but in general, people seem to get better. And there's a lot of interesting work going on about the autonomic nervous system, the role of deep breathing in terms of re-regulating the autonomic nervous system. And so I'm really hopeful that we are going to get some answers that may help patients in the long run. probably it's related to the immune system sort of getting turned on and then having a hard time turning back off again. So it's hard. It's real. People are experiencing this, and I think the healthcare community owes it to our patients to listen, to work with folks, and to do what we can to understand what the symptoms are and how we might get them to feel better. There's a smaller group of people that after COVID do go on to get, things like chronic lung scarring that affects their oxygen levels, or heart injury that affects their heart function. And the other part of the medical community is to try and be thoughtful about testing to try and identify those folks that may have some other illness form that would benefit from different types of treatment. So it's a long answer, which is basically we're learning a lot. It's real, and I think we need to keep paying attention.
Dr. Mahani, anything to add from the ICU perspective as far as long haulers or the lingering effects?
Yeah, it's interesting. One of my other hats is as a pulmonologist. Well, I guess I'll start with, can you hear me?
Yes.
Okay, good. One of my other hats is working as a pulmonologist, so a specialist in lung conditions, and I work in a clinic. And, we dealt with the wave in November and December at Mary Greeley, and now I'm actually getting somewhat of a wave of clinic referrals for patients who just don't feel like they've recovered. And the spectrum is it's quite large, and it's all equally frustrating. There are some people who just continue to feel short of breath and just don't feel like they've made it back to what they were able to do before. And it's frustrating for them. We'll do CAT scans, we'll do breathing tests, and it may be normal, and it doesn't mean they're not having those symptoms. But their objective testing is normal. Our approach at that point is give it time, make sure we're not missing something, and continue to try to do no harm. There are other people, like Dr. Fulton referenced, who have some degree of scarring in their lung. And the question is, how well are they going to recover? Is that going to go away? When we use the term scar, we imply that it's not going to go away. So I try to call it inflammation to try to create some optimism that maybe this can improve. And I've seen some people improve. I have seen people yet to improve. It's only been a couple of months, so it's too early to tell how true of scarring this is going to be, but there's no doubt that there are going to be left with scarring in their lungs.
Dr. Fulton, we got an incredible amount of questions about the vaccine. That's really what people, I think, are mostly interested in. Specifically, what would you say to people who are not going to get the vaccine for a myriad of reasons, whether they are worried it came together too quickly or the side effects? What do you say to people who are vaccine hesitant?
That's a great question. I think the first thing I've been saying, and that I think we should keep saying, is this isn't something we should be fighting about. We still have massive vaccine shortage nationwide and worldwide. There are a lot of people out there that do want to get vaccinated that don't yet have access. So in terms of, folks that are not sure they want to be vaccinated, I think my perspective is this is, to me, that's sort of a low priority group, because there's plenty of other people that we just need to move forward with and who want to move forward. I think folks that have vaccine hesitancy are a diverse group. I think people come to that point for a number of reasons. I've heard many people say they want to get the vaccine, but just not yet. They want to see how it plays out over time. And I think there are people out there that absolutely not. They don't want to get a vaccine, and there's not a lot you can say to convince them. I think people are generally curious. I think people, can take the time to ask questions. And I think, so for example, if somebody has a loved one that is maybe hesitant, I think try to get good information in front of those folks, either the actual studies of the vaccine, which are available for review, or advice from, a trusted family doctor or somebody that, is more than maybe information that they've gotten off the internet that might not be as reliable. at the end of the day, I think people just need to keep asking good questions, try to understand what they're seeing, and be open to new information as it comes in, as we're doing. As we have now rolled the vaccine out to 50 million people in the United States, we continue to monitor for unexpected side effects, through the monitoring systems. And, so far, so good. We haven't seen a large signal of an unexpected side effect. Unfortunately, with any vaccine, any medicine, there are rare things that can happen that are impossible to predict. Those are stories that often, I think, get told, but I think they get told at a disproportionate level to the 50 million folks that otherwise have done pretty well. So I think the answer is my third rule, which is kindness counts. And, if we can all just extend each other some grace about getting the information we need to make good decisions, I think it'll work itself out.
Remember when vaccines were first coming to Mary Greeley back in December, we talked a little bit about it, and you said, every vaccine is just yay. And you did that motion, yay, which is, really true. Every vaccine is just another step closer to normalcy.
Well, I do think that if we think about our community, if we think about at whatever level we define community, every vaccine that is done, and I believe they work. I've gotten it myself. I've encouraged my family to get it. So every vaccine that gets done is a victory for everyone, because it's one less person that can get infected or pass on the virus to somebody else. And those links in the chain feed forward over time. And the more links that we can break with the vaccine, the less disease we'll have in the future, and the less this virus will have a way to continue to disrupt our communities. So huzzah, take a community approach, and imagine that every vaccine is a victory for everyone.
I'm going to bring everybody back here in 1 second, but just quickly, the Register and many newspapers have been trying to get into hospitals to tell stories for months, for a year. And a lot of the pushback was, of course, around the pandemic and spread concerns, but also some concerns about HIPAA or patient privacy. Obviously, Mary Greeley did, in fact, open their doors and allowed us in. So I'm wondering from either of you, what was it like to have the press come in? And do you think it was a beneficial thing at the end of the day?
I'll start. So I was told a couple of days before you guys arrived that you guys would be joining me for rounds in the ICU. And like we've talked before, I try not to be a very public person. I try to just kind of keep within my friends and family circle. And there was a lot of politics going around about this virus and what we should and shouldn't be doing. And my initial concern was you guys would be working with us and kind of asking gotcha questions, and how do I feel about this, and how do I feel about this, and the governor, and all sorts of things. And it was very quick that I realized that both you and Zach were not there for that at all. You were really there to observe and learn, and just tell our stories. And so I think after, I don't know, very quickly, I just became very comfortable with you and Zach being there. And I think very much credit to all the patients who gave you guys permission to tell their story, because they're very vulnerable at that moment. And I think overall it was a great experience for us to have you there, and hopefully the public as well.
I think one of the biggest challenges of COVID has been, because of its contagious nature, how hard it has been to not have families around when patients are sick, and to not have these stories told. So in some ways, we've had 500,000 people die, and those stories have been very hard to tell because of, an appropriate focus on patient privacy. So I agree with Dr. Mahani. The patients and their families who agreed to be a part of this story, I think are really heroic, because these stories have the ability to share what's truly happening and what what is, if the stories can be told, I think those stories can change the way people think about this pandemic. And I can't say enough about all of our patients and families, and then you all who kind of braved the hospital and came in and took this on. We really appreciate it.
Thank you.
And the administration too, the hospital, I think they did the right thing, and they knew these stories needed to be told. So
absolutely. And you guys are heroic too for allowing us to follow you around and tell those stories as well. I want to bring everybody back in for kind of a last question here. And those of you, we interviewed all of you, so you should know this question. I'll popcorn and have you guys answer. Mahani, I'll start with you. What do you know about yourself or your team because you experienced this past year of the COVID pandemic that you don't think you knew before?
That's a good question. And I don't have a very profound answer, but I'll try to answer that. The first thing is that I stress eat. I didn't realize how badly I stress eat, but I do stress eat. That's not my real answer, but I think as we reflect on the past year, there were a lot of people who stepped up to new ideas, new things that we were not comfortable with. And there's some groups in the hospital that aren't getting who aren't getting talked about very much. And I think our respiratory therapy department, there might be the only department in the hospital that has actually seen every single COVID patient, just by the nature of the disease. They're upfront and personal, giving nebulizers and inhalers, and our hospitalist group, physicians who work specifically in the hospital, have done an incredible job. Our emergency room physicians and our emergency room staff and all the techs, really the pharmacists, keeping track of what should we be using, what shouldn't we be using. A year ago, we were talking about Plaquenil. In our anesthesia department as well, they really stepped up to the plate, particularly in the ICU in the last year. Hey, this was really stressful, and our ability to manage stress was tested. And our ability as a team to step up and communicate and get through this, and some of us had bad days, me included, some of us had good days, me included. We were all there for each other, and I think that's why we were able to do this. I had my concerns. We're not a big hospital. We have a small team, but everybody stepped up, and I thought as a whole we did a great job. And I want to clarify that. I say doing a great job, because this is continuing to be an issue.
Good point. Margie, popcorn to you. What do you know about yourself or your team because you lived the past year that you don't think you knew before?
I think everyone's realized how important family and your actual health is, for everyone to be healthy, and everyone's appreciated that now, or change ways to be more healthy. But as far as our team, I think it's been really, really neat to see how the whole hospital changed to work together, like from every department, and how it takes the whole entire hospital to make adjustments to make everything work. Like, we could not do things without environmental services or dietary or the door screeners, or the doctor's professional input. So I think it's been really neat to see how healthcare is so essential and so important, and how we're willing to adapt and change for the community and for the better good.
And Julie, over to you.
So I learned over the past year really that we had to be flexible. And Dr. Fulton always told us to be kind. And I think we had to remind ourselves sometime of that, because it was very difficult. Things changed by the minute, by the hour. And, 1 minute we'd be doing something and then we'd have to change. So I learned that I can't have everything in my square little box and everything, packaged the way we want. It was continuously changing. I learned that I had to acknowledge my team's sadness, their heavy hearts that they were having. I get a little emotional because I had one of my strongest nurses come to me one day and she just burst out in tears. And so I, had a leadership coach and I went to him and I said, what can I do? And he just said, you got to stop being positive. And again, that's something Dr. Fulton and Dr. Mahani and other team members here said is, this is real, this is heavy, this is a lot to do on a daily basis. And so I learned that I can't always be positive and make everybody feel positive and stay positive. And, our community stepped up and brought us food and snacks and treats. And that was wonderful. But really, I had to learn to acknowledge that there was a lot of sadness, and there still is. Like Dr. Fulton keeps saying too, is we packed away these feelings, and they're still there each and every day. Like you said, we have one patient that's not doing well today, and when we talk about that, and when we see that, it just kind of gets those feelings back up. So we have a little bit of a break, and then it comes back. So I've learned a lot. I've learned that my team here in the intensive care, our administration, these physicians, again, a lot of people in the hospital, the ACS nurses who, like Margie, thought they were going to, just take care of patients and discharge, are now coming up to take care of some of the sickest patients at the hospital. So I learned that we are a great organization, a great team, and we kept learning to get better each day.
And Dr. Fulton, round us out with your answer to that question.
I think I learned just how much we can depend on each other, even in hard times. And I want to tell a story about our med surg floor. For a long time, we kind of had a natural divide on that floor where we could have half of it kind of dedicated to folks with COVID and half still working with post-operative patients. And as we got into November and we were surging beyond that half, the initial plan had been to use a completely different unit in a different part of the hospital to kind of take care of that next level of the surge. And Margie and her team basically said, no, we know how to do this now. We're experts. We are dedicated to this process, and they really wanted to take that on. And I think that just speaks to the level of dedication of our teams here. And we just saw that time and time again across the board, all the different folks that Dr. Mahani mentioned. And, even beyond the hospital, in the community, the URI clinics that a lot of these folks have already been to beforehand and are being monitored at home, or even community leaders working with the schools and elsewhere, it's really been a moment for everybody to work together and depend on each other to get through something that was really hard, and an opportunity to really lean into our training and our professionalism and do our best. So I just have so much gratitude for all the work that everybody's done.
Margie, Julie, Tamim, and Dan, thank you so much for being here today and answering questions from our audience. We at the Register were honored to be able to tell stories of triumphs and struggles inside the hospital, and we really want to give credit to Mary Greeley for allowing us in to do so. We invite all of the viewers to read the series at DesMoinesRegister.com, and I'll go ahead and tweet it out after this, Courtney Care on Twitter. We're going to leave you with a short video that I think really puts a cap on the last year. In it, you're going to hear Dr. Fulton talk about the importance of really caring, deeply caring for people and for your community, because when you are at the end of yourself, when science doesn't have the answers yet, when nothing is working, you can always hold someone's hand and you can always care. Thank you so much for being here, you guys. And here's that video.
The pandemic has laid bare so much about what it means to be a human. 3 months ago, when we were at our peak, to now it's a completely different world in the hospital. It's almost like eerily quiet. I just feel like if we found out that we were getting another wave next week, I would not be surprised. Anything in particular, those are negative.
Okay.
I think it's going to take a while to get over that discomfort. But it's the kind of feeling that you have going through something like this with others that feels sacred because you've never been through it before, and there's nowhere else you will ever go through it again.
I didn't have any coma on board for 6 hours.
Good. I don't think that'll happen again.
I hope not. That was terrible.
Weird bad luck. If there's one thing COVID taught me, it's how important our human interactions are. Good. That all bodes well. That's all good news. I think the moral of the story is that we need each other. And we have found a way to be together the way we could